Greetings, I'm Dina Wilkie, and this is my presentation on patient handling in home care, an ergonomic analysis. Despite extensive ergonomic research and interventions for patient handling in various care facilities, caregivers in the home care setting remain at considerable risk for work-related musculoskeletal disorders, most prevalently low back pain and upper limb disorders. This analysis explores the impetus that home care needs to be a high priority in both understanding ergonomic exposures and developing flexible interventions that are drastically different from the traditional hospital settings. By more so generalizing applicable ergonomic assessments, the so determined ergonomic deficiencies, and according recommendations for addressing them, along with the benefits that may be realized. While some caregivers in the home setting are employed by home care agencies formally, many others are patient family members or privately employed individuals. Therefore, lacking regulation and oversight, they comparably lack protections as they perform manual patient handling tasks. For example, state legislation, which requires healthcare facilities to implement comprehensive ergonomic programs to protect their workers, may exclude them. Financial constraints further decrease the likelihood of assistive devices being present in a patient's home or otherwise available. Furthermore yet, these caregivers may simply not have knowledge or training in safe patient handling techniques. Altogether, this means that each patient-caregiver interfacing is dictated by unique physical and organizational factors. This analysis considers three main patient handling tasks conducted by caregivers in the home, which vary in location and combination. Lifting, for example, in or out of a bathtub or from sitting to standing. Transferring, for example, moving from bed to wheelchair. And repositioning, for example, in bed or boosting up in a chair. Although there are myriad measures with which to assess the ergonomic risks of patient handling, the home care environment especially precludes the feasibility of most assessment tools. With that in mind, this analysis considers the application of two possible assessment methodologies. Now, to summarize the applicability of these two assessment methods. Practical problems limit the use of direct observation and measurements to assess exposure to patient lifting in real-life settings. As contextualized, a more passive method may be more readily and effectively applied for home care. Logging of patient handling activities is a way for these caregivers to account their exposures firsthand. Consequently, this analysis foremost considers the example of the lift counter, a 7-day log designed for self-administration. It's frequency-oriented and provides relevant information for designing back pain prevention. Furthermore, it's designed specifically for patient handling and its exposures, so is therefore preferential to a more standardized questionnaire. Secondly, although the movement and assistance of hospital patient method was developed with the hospital setting in mind, its inclusion of the various factors such as work organization, average frequency of handlings, types of patients, equipment, environmental conditions, and training, along with its quickly analyzed data collection sheet, make it favorable to the home setting also. According variables in the equation generate a risk value indexed at negligible, medium, or high. Results have shown a positive association between increasing levels of MAPO index and the number of episodes of acute low back pain. Additionally, it was endorsed by the 2012 ISO technical report as a useful tool to plan tailored preventive actions and choose suitable equipment for different types of patients. The reality of this work situation's strenuousness is undoubtedly underestimated by any modeling or observation in a controlled setting. Additionally, the duration of patient handling tasks are typically only a few seconds, thus ergonomic focus tends to be on other aspects. Lifting, transferring, and repositioning patients manually is characterized not just by non-neutral posturing alone, but also heavy loads. Numerous studies have correlated higher back pain prevalence rates with caregivers lifting patients more frequently, and therefore corroborates the premise that every manual patient transfer could present a nominal risk for the occurrence of back pain. This concern regarding frequency aligns with various biomechanical studies which report that the magnitude of the load is such that acceptable biomechanical limits for the backload are exceeded during various manual patient transfers. Recommendations for addressing these deficiencies bear in mind manual materials handling best practices and the hierarchy of controls. This work situation leaves little likelihood for the most effective means of intervention due to the nature of this care work, being both vital for many patients and financially and otherwise constrained. The home environment is often not conducive to mobility and so impedes the application of solutions that require certain physical parameters, working surfaces, etc. Therefore, to reduce caregivers' exposure to the WMSD risks inherent in patient handling tasks, it's likely that controls lower on the hierarchy must be implemented. And while it is beneficial to augment these tasks and reduce caregiver strain or exertion, there remains the risk of acute trauma causing a WMSD. Whenever feasible, though, mechanical hoists or lifts should be introduced. This may eliminate patient handling tasks for a caregiver due to someone else, like a relative, being able to complete the task instead. Regardless, an elimination effect should be created by using such a mechanism, due to it replacing several manual transfers with one. For example, a hoist needs one transfer to go from lying in bed to sitting on a toilet, whereas the manual alternative often results in one transfer from lying to sitting, a second from bed to wheelchair, and a third from wheelchair to toilet. If the caregiver is themselves a family member or the introduction of a mechanical hoist or lift does not otherwise eliminate their patient handling tasks, it can at least substitute for some of the manual patient handling required of them. Whenever possible, other assistive devices, known by many names, should be used, such as slide or transfer boards, slide or lift or draw sheets, and gait belts. Additionally, generally affordable and patient-centric aids can be introduced, such as shower chairs and raised toilet seats. Adjustable height beds are also beneficial. What all of these ADs and aids have in common is their ability to redesign the manual patient handling tasks to be more ergonomically sound, by reducing the load a caregiver must bear and/or improving their postures. Some, like the boards and sheets, alter the working surface to eliminate friction and thereby reduce biomechanical stress for the caregiver. Any iteration of a lift transfer or repositioning could be quantified via the NIOSH lifting equation or some other assessment tool, yes. But the crux of the matter is that virtually no two would be the same. Crucially, with or without ADs and aids, caregivers should receive proper training on how to safely conduct patient handling tasks. It should be duly appreciated that these introduce their own risks to the work situation. Home care agencies should provide pertinent training to their caregivers, but others may be able to self-direct their learning via online or community resources. If possible, scheduling could be utilized to reduce caregivers' frequency and duration of patient handling tasks by managing their exposures to higher needs patients. The myriad constraining factors heretofore discussed also mean that quantitative post-intervention evaluations are limited in the home care sphere. Nonetheless, as demonstrated, the hierarchy of controls provides guidance for caregiver protections contingent upon each unique home setting's limitations. There is inarguably merit in reducing caregivers' patient handling exposures and introducing means to perform the residual tasks more safely. This is inherently participative due to it being dictated by both caregiver and patient anthropometrics and abilities, ever-changing and subject to influence from the home environment. Generally, the expectation should be for exposures and therefore WMSD prevalence to decrease. Pilot testing of the recommended scheduling changes suggested reduced fatigue and pain, which is beneficial for limiting the cumulative nature of exposures that contribute to WMSDs. As a qualitative example, all caregivers who received a training in safe patient handling and mobility believed they decreased risk of personal injury. Often, caregiver compensation isn't involved or isn't formally tied to employer responsibility for worker safety. When it is, though, companies could certainly compare cost of implementation, acquisition of ADs and training, for instance, versus resultant savings, for example, in workers' compensation costs. Also considering the connected issues of absenteeism and turnover. As evidenced by the literature review informing this report, the attendant risk factors of this work situation are well established, but due to its fluidity and complexity, it's a matter of further insight and higher level solutions being critically needed to better understand and mitigate the barriers to optimization and WMSD prevention. As described in the human factors of home health care. Here are my references. Thank you for your time.